Good morning, ladies and gentlemen, and you're very, very welcome. Thank you for giving up a Friday morning to be with us. I think you will find it worthwhile. I'm going to introduce the first two speakers, Subir Banerji and Shamir Mehta, who are right in the absolute forefront of tooth wear, not only its treatment, but also its research. You'll be interested to know Shamir is just about to finish a PhD on that very subject. They're going to, the title of their talk is Conversations About Tooth Wear, and that's exactly what it's going to be. I've seen them in action before, and it's a really novel and very nice way of actually covering a subject. But very briefly, I'll tell you about them. Between the two of them, they run the MSc in Aesthetic Dentistry at King's College, London, and it's a very, very nice course. They've published jointly, fabulous book on tooth wear, and lots of research. In fact, they're right in the forefront of that. Subir is in practice in London, as well as his other job at King's College. He also is an external lecturer at the University of Melbourne, and lectured widely and published widely on tooth wear. So nobody better than these two to actually speak about it. Shamir is also in practice in London, and he completed his Masters in Clinical Dentistry in Fixed and Movable Pros in 2005. You'll all be interested to know that he's also the Senior Clinical Dental Advisor Fitness to Practice at the GDC, so they're very fortunate to have a person of such great sense and knowledge. As I say, he's doing his PhD in tooth wear. I don't think there's anyone better to actually give us a conversation about tooth wear than these two gentlemen. So, ladies and gentlemen, I wish it was live here. Let's welcome them. Subir and Shamir, thank you so much for joining us this morning.
Thank you, Trevor, for a wonderful introduction. It truly is a privilege and an honor to be a part of this, and thank you to the BDIA for giving us the opportunity to share our work with our colleagues who are joining us today, and it's truly a pleasure to be here. Thank you.
Thank you, Trevor. Yeah, thank you, Trevor. Delighted to be involved with this and speaking about tooth wear to the audience.
Great. So we'll make a start. There's a lot to cover, and I have to say that this is quite a novel experience for both of us to be able to talk to you through technology. And I'm keeping my fingers crossed that everything actually works to plan. I've got this. I feel myself in the forefront of technology with all these gadgets in front of me, with the phone remotely controlling something far, far away. So let's hope it all goes smoothly. But it's indeed a pleasure to be with you. So without much ado, we have a lot of material to cover. So we'll start off. And let's see if we can forward the slide there. Let's give it a go. And right. So the first hiccup is that I can't seem to be moving the slide forward. So I'll try to have another go. Yes, there we go. So it's gone forward, and looking at this picture, what we would not give now to be able to travel again. This is about from 2 years ago. Shamir and I were part of this European consensus meeting in Nijmegen. It was a wonderful occasion where we were joined by experts from around the world to talk and discuss about tooth wear. So it was a wonderful experience then from two years ago. And quite like-minded people getting together to talk about a subject which I think was quite important and very prevalent for nowadays. And the idea really was to actually the culmination of this was coming up with a paper on severe tooth management and looking at a consensus statement. And what we had this published in the Journal of Dentistry, and it really covered points which we felt were very relevant in this topic of tooth wear, and in particular having quite producing some guidelines or extrapolating some guidelines which allows us to kind of look at this problem clinically in our clinics and as they present in our patients. So this was the consensus paper that was published in the Journal of Dentistry, and a lot of what we're going to say is centered around here from this paper, and taking out bits and pieces from it, which I think are very relevant for clinical practice as we see our patients in practice. And the very first thing I picked out was the definitions of. It was important to actually get down some definitions to actually have a starting ground from where we could actually build our understanding from. And Shamir, I thought this was quite a nice way to actually start off, in the sense that we actually have now a physiological tooth wear, a kind of a measurement that was given for what's known as physiological tooth wear.
Yeah, agree. I mean, tooth wear is different from the other two most prevalent dental conditions, caries and periodontal disease, in that they don't take place as part of the natural aging process, whereas tooth wear does, and therefore, physiological comes into it, and there is that need to define that stage when it's normal aging and when it isn't, and I think that kind of nicely takes us onto the next slide.
Yeah, but just before we do, actually, one thing that I did feel on this about when we reached this agreement about what physiological tooth wear was going to be, and I'd like to know your thoughts on it too, is that, of course, these are from measurements from one part of the world. I have done some work in different parts of the world where tooth wear is very, very prevalent and very common. And my kind of observation is that what perhaps physiological would be termed of in a different part of the globe might be very different from what we felt here. Did you feel that as well in your research you come across?
Yeah, I mean, it's not a specific area that I've researched on, but you're quite right. I think you do see differences globally in terms of levels of wear, and I guess the other thing is that even when you look at various age groups, although there's a wear rate here, in terms of what levels of wear you would expect to see within the various age categories, they're not clearly defined at this stage. But to me, the most interesting thing here was that, where you've got a disease which takes part of the natural aging process, as opposed to the other two, and just sort of in your mind working out, what is normal and what isn't.
Yeah, and I think, as you rightly said, the next bit was to actually look at, following up from that, what pathological tooth wear was, and of course. And I think both you and I felt that, bringing in a sort of a definition come a parameter on which we would actually look at pathological was quite important. And here, of course, the age of the patient comes into play as well. And I think you felt this was quite an important statement to make as well.
Yeah, absolutely. When we look at sort of previous definitions of pathological, the center point was what was excessive for age. And, when you're using the term pathological, which implies disease, you may well have somebody who's got slightly more wear than what you would expect for that level of age. But to sort of label it as being pathological, it doesn't quite give it the right context, whereas this definition, which brings into play symptoms and signs, etc., I think just gives it that much more context than what older definitions have had. And I think this was one of the beauties of that consensus meeting, in that it brought together a lot of opinion, a lot of experience, a lot of knowledge, and distilled it down into that one document. And I thought that that was a really big turning point.
Yes, I agree. And I think this scenario where it was the relating it to, I'm just thinking of the patient in our clinical chair and seeing the patient, where a lot of the times patients don't actually complain of any symptoms, but we're kind of observing a scenario happening, and we are looking at, of course, we linking patients' symptoms like functional and discomfort, maybe sensitivity, but also some idea of the aesthetic aspect of it, and of course, as you say, disproportionate being of the age. So there's a sort of a clinical element that comes in where the clinician may be a little bit concerned about what they're observing in a patient, as well as from the patient perspective. And that's why I felt that this was an important definition to come through. And of course, this the next one on severe tooth wear was a very interesting one, because indeed clinically we find that looking at the amount of tooth loss, on a particular, and it could very well be localized almost down to a single tooth, as well as generalized. And I felt this was quite an important feature to bring out as well, of what we observed clinically.
Yeah, absolutely. I mean, one of the areas that I work on is looking at longevity or performance of restorations. Specifically, we're looking at composite restorations. And one of the difficulties you have, and there's probably a dozen or so papers on this subject area, is when you look at these individual studies, what they infer to be severe can be a little bit different. And therefore, when you're trying to make comparisons, it's very difficult because what somebody may interpret to be severe may be quite different to what somebody else does. And therefore, you can't necessarily make direct comparisons on the longevity. And I think this definition, again, gives some, obviously it's part of a consensus. It gives an agreed definition, which I think is very important going forward, but also helps to define, as it says by definition, the highest level of the index. And again, I think encouraging colleagues to use an index to quantify levels of tooth wear gives a lot more context than sort of saying mild, moderate, or severe. And the use of an index certainly would be encouraged.
Yes, it's interesting you brought that up, because of course there are quite a few indices, and I think we may during the course of the presentation touch upon a few, and there's they have advantages and disadvantages. Some are more commonly known than others, particularly globally. I think some of the work we did together, we found how particular indices were perceived globally, and it's not as uniform as we would like it at the moment, but it is an area to allow how we could actually monitor and record tooth wear, which I think we both agree that this is something important to do in clinical practice, because it's important to record what we're seeing. It's like recording a disease process, and of course then how it sort of progresses from there is very important once you have that. So I think you touched upon an important point. Then perhaps you can actually elaborate that a little bit more as we're going through on the presentations. And so therefore, when looking at pathological versus severe, really speaking, is we're looking at something that is to do, one is to do with the rate and one is to do with the amount of tooth wear, which is quite a nice distinction to have sometimes clinically in my mind, well, particularly being in general practice myself, when I see my patients, to have this in my mind about this, sort of how I would look at a patient and categorize this. So the definitions here were quite important, and I think you felt the same about this as well.
Yeah, and I think we will touch on that with the the next set of slides, in that you may see something which isn't severe but is pathological. Likewise, you might have a patient with very low levels of wear, but it's causing symptoms. And I think having these, having an understanding of the difference between the two terms, and of course defining them is important.
Mm-hmm. Yes, and I think as we see the slides and as we also see a few cases, this will become a little bit clearer as we go along, I hope. And so here we've got a sort of a picture. This is actually from our colleague Bas and Nick's library and from Nijmegen. And here we see an adolescent, of course, a young patient with some sensitivity. So therefore, this will be classed as more to do with the kind of rate rather than the amount of wear. So in other words, it's pathological but not severe. And of course, this we do find this as a common occurrence, and particularly sensitivity, signifying that something is quite actively happening.
Yeah, absolutely. I agree with you completely on that.
Yeah. On this next slide, we have severe but not pathological. Obviously, a lot older patient. There is severe tooth wear. There's a significant amount of tooth loss, but of course, given the age of the patient, not necessarily pathological. And I think this is an important distinction to also make when we see these kind of patients in practice, as we see a lot of them. And I think you see a lot of these patients in your practice, Shamir, don't you?
Certainly around the area where I'm based, there is a larger elderly population, and we do see a lot of wear. And this was sort of the thing that got me interested in wear in the first place. When I first graduated, I would see patients like this, and there'd almost be this compulsion to do something about it. But at the same token, it wasn't causing the patient any problem. And I think that the key thing now is that, when you see something like this, clearly you're going to, carry out your investigations. And, we talked about symptoms. It's important to just sort of probe into that, patients sometimes won't tell you, how they really feel about the way they've got in terms of, the social or the psychological impact. And certainly work that we've done has shown that there is a link between severe wear and the psychosocial impact that it might have. But, nonetheless, as part of the process of, your examination, you should sort of discuss your findings. And in the least, there would be no reason to not prescribe, appropriate preventative care for such a patient, even if they don't have any symptoms. And I think, again, these sort of definitions certainly help, how I would manage these things, and they would have been very helpful 20 or so years ago.
Yes, indeed. And so kind of looking at these definitions kind of clarifies in my mind as well when we look at these patients. And of course, this next slide is fairly explanatory. I think I just had a little hiccup. Oh, there we go. And which is pathological and severe. So here we're actually seeing both rate and amount. And of course, quite a few of our colleagues might identify with patients like these, where they're actually seeing both a combination of both systems. Yeah, and of course, these patients are very difficult to treat as well.
Yeah, I mean, these when we get these sort of cases, they're almost a nightmare. But it's just taking that logical approach to this, and then knowing, where for you as an individual, where you kind of take a step back and where a referral might come in, et cetera, et cetera. But certainly, when you do get these sort of things, there is that need to sort of diagnose appropriately, et cetera, and, make appropriate records and do whatever else is required in the best interest of the patient.
Exactly. And so here we kind of also came upon this sort of flowchart, which I thought was quite important and gives us sort of an overall picture of perhaps how we would manage a patient with tooth wear. And as you rightly pointed out, for a lot of patients where we're actually in the prevention mode, where prevention is a very important component of tooth wear, of course, recognizing it early and instituting sort of preventative measures, and some of them we'll highlight later on in the presentation. But this flowchart gave, in my mind, a sort of a nice way to actually perhaps approach a patient who might need management, might need active restorative management as well. And what was a highlight for me here is that the step after prevention is after all the preventative measures have been instituted for the patient, to ask the question is that whether tooth wear is a cause for a patient and or the clinician. And this, in my mind, actually gave a very clear, defined definition of when, if or not, we would like to intervene restoratively. So if there was no concern from the patient's point of view or the clinicians, then the patient will stay within this preventative cycle and the prevention would be reinforced. Or if there was a concern, whether it be symptomatic, aesthetic, and or from the clinical point of view, looking at something that if we didn't intervene, it might get progressively worse, and therefore the treatment might get more complex, then to actually do the formulate the treatment plan with informed consent and have the restorative intervention, which we'll both talk about in a while, but then of course complete the loop again with the prevention. So I felt this flow chart did give a sort of a nice overall view of how we perhaps would manage the patient in practice.
Yeah, absolutely. I couldn't agree more. But if I could pick up on one component of the flowchart, it's the bit at the beginning with the risk assessment, and I think that's quite an interesting one. In that, some of the work that we've been doing in terms of research, what I found was quite what made it an interesting finding is that we looked at about 300 practitioners in the UK and overseas. And we looked at sort of practitioner habits, and what we found was that most dentists would agree to risk assessing patients with tooth wear, which highlighted the awareness of the condition, which is heartening, especially given that it's the third most common form of oral disease. But what was I found very interesting is that when we asked the same sample about whether they would risk assess if they saw a patient with severe wear, and we found that only 60% said that they would. Furthermore, on top of that, and we were talking about indices before, only 13 to 14% of our sample use an index. And if we were to look at periodontal disease, and we sort of said, well, our findings have shown that you've only got 13% doing a VPE, I think most of us would find that quite shocking, really. But you see quite a big disparity between the two conditions in that with the number of individuals actually using an index and sort of screening, etc., and charting, and I think that kind of highlights that the awareness is there. There's just a bit of work that needs to be done with getting colleagues sort of assessing more frequently, keeping those records, providing the appropriate prevention based on the diagnosis. But I think this sort of flow chart gives a very sort of concise way of sort of managing the condition.
Yes, indeed. And I do apologize, in the middle there was a slight advance of the slide which wasn't meant to be due to the technology there. But this next slide basically sort of summarizes how we used to look at the etiological factors. And of course, we do recognize the tooth wear being multifactorial in its etiology, and therefore we have the erosion, abrasion, attrition, abfraction. I think most of colleagues and people who dealt with tooth wear are familiar with this kind of approach of looking at etiological factors. But what I've found quite useful is actually just to sort of perhaps looking at this aspect and recategorizing it a little bit, in my mind made it a bit clearer, where you kind of divide them into chemical and mechanical, chemical being mostly erosive, of course, and then dividing that into a intrinsic and extrinsic source on there. And then, of course, in the mechanical aspect as well, you would have the extrinsic and intrinsic as well, and underlining that, of course, the etiological factors in majority of cases are multifactorial, although you might have one particular component that is predominant in the tooth wear, but it is multifactorial. And I felt, Shamir, that this sort of outline or sort of breakdown rather than the previous one, in my mind, made a lot of sense, and again, relating it clinically or what I see on that.
Yeah, and I think, of course, I agree with that. And I think to sort of add to it, it's very important, going back to the basics of history taking, trying to identify what the etiology is. And as we said, it's multifactorial, often where there's an erosive component. Because if you're going to manage the condition properly, certainly if you're going to go down the route of restoring it, if you don't manage to identify what's causing the problem, there is that risk that your treatment could be significantly compromised and the restoration fell prematurely. So it's very important to identify what's causing it, deal with those factors as best as possible, and there's no reason not to to at least get to that stage of the prevention. But where this sort of approach is that much more beneficial is that there are studies that have been done using cluster analysis, which can sort of lead to certain definitions of phenotypes, which can help the clinician identify whether it might be chemical, mechanical, or perhaps even both. And again, you can apply those to try and diagnose accurately. And I think it's so very important to do that and to manage the factors before going ahead and doing anything any more sort of explicit. We know that restoring cases, as we'll get onto, is quite expensive. It's very difficult, and the last thing you want is everything failing because you're not sort of dealt with the basics as well as you should have.
Indeed, and I think one of the other things that came out here also was, and I think we've chatted about this between us regarding this kind of correlation a little bit about certain stresses that may make certain areas of teeth a little bit more vulnerable for non-carious tooth surface loss. And of course, this is still slightly controversial. I'm really referring to things like abfraction and where you have got these lesions in the cervical areas, these non-carious lesions in the cervical area, and I think there is a lot of debate still about that. But there is this thought process about how perhaps some sort of forces or perhaps occlusal forces may lead to a surface becoming more vulnerable to perhaps abrasion on there. Again, like I think we've discussed, and I think you confirmed also that we're still looking at certain aspects of the research about this, but it is important, I guess, to bring it out in the sense of when we actually deal with it as well. But there is a bit of still about debate about that, I understand.
Yeah.
So talking about now managing the patient on particularly the sort of prevention aspect, I just thought, I know there's a lot of talk about it and there's a lot of written about it, but what I thought we'd do in one slide is actually just bring out some highlights on there and a few sort of take-home messages. I think nowadays, I was listening to a presentation yesterday regarding Regenerate, which sort of a paste serum mouthwash that can actually allow some sort of a mineral layer or deposition on enamel and dentine and some and there's lots of other pastes like that. But in addition, a few things that sort of came out from here is quite interesting about this thing about the use of a toothbrush and how sometimes with using a soft toothbrush, which actually kind of is a sort of automatic choice sometimes for tooth wear that we ask patients to do, that can sometimes, of course, compound the problem because of the fact that it retains more paste, abrasive paste, and then when it's used. And the other thing that here, I guess, is whatever reinforcement dietary or that we're doing, it has to be reinforced periodically in order to be effective, as a lot of research has also shown. But I just thought on this slide, we have some sort of a summary of the main things. And anything else to add to that, Shamir, on those?
Yeah, I mean, there was a few interesting things, with the soft brushes. I guess when we're looking at things like acidic drinks, one's also looking at the buffering capacity of the drink, in that it may have a very low pH, but it might have a better buffering capacity. And therefore, sort of learning a little bit more about what causes the damage, might be helpful. Again, I think occlusal splints is an interesting one. I know we're going to talk about it more in the next session. But, patient compliance with these sort of things, it's great we provide them, but, it's interesting to know that how many of them will actually wear them. So yeah, there's some important take-home points on this slide.
Yeah, I think the other thing to mention, I know we might actually cover this in splints as well, but if you are suspecting a patient with intrinsic chemical erosive issues, then of course you may choose not to provide a occlusal splint, which may act as a kind of a reservoir. And I'm thinking of GORD here, esophageal reflux. And you may choose not to actually use a splint for patients like that. So coming to the management, looking at the restorative management, here's when we've kind of looked at the patient, we've kind of determined that it is a concern for the patient, whether it be aesthetic, functional, sensitivity, or from a clinical point of view, where as a clinician we're worried. We're actually going to look at restorative management, and I thought we'd sort of kind of highlight the certain aspects, important aspects. Is given the time that we have, it's difficult to go in every little detail of it, but I just thought we would highlight certain principles that are particularly relevant when we're looking at dealing with this, and looking at localized tooth, where in particular, whether it be anterior or posterior, or with a single tooth or a group of teeth, is the concept of looking at it. And this concept of relative axial tooth movement, which we're quite familiar with now, and I think we've written and researched a lot on it to look at this, using this phenomena, if you like, in order to help us deal with these cases. And so using certain cases to illustrate this, Of course, this comes from Dahl's work from previously. A lot of people, I think majority of our colleagues will be familiar with this, sort of following up with it was done quite a long time ago in almost the 70s now, and has been well looked into in detail by a lot of researchers. And when we look at this, is looking at this concept of where you are looking at sort of minor movements of teeth and utilizing it in order to create space for these restorations, and in particular allowing a sort of the passive re-establishment of the occlusal contacts within the other teeth. And I feel that this aspect has really kind of paved the way of how we would deal with these patients in a minimally invasive way and in an additive approach. And I feel that in practice in myself, and as we look at certain cases, and I'm sure Shamir will have something to say about this as well, that this has really kind of changed the way in which we look at managing these patients in a restorative manner.
Yeah, I mean, when we go back to the consensus paper, one of the sort of take-home messages is that where possible, try to treat wear cases restoratively in an additive, minimally invasive way. We know that although crowns, and we'll talk about this later on, can offer a very good prognosis. Obviously, when you're going to place them, there will be the need to take away a lot of tooth tissue, and it seems bizarre to be drilling away more tooth tissue when what you're trying to restore is a worn dentition. Bearing in mind that these things don't last forever. So, the application of this concept is fantastic for the management of wear. And I think one of the things to also highlight is, if you look at the slide, it refers to anterior bite platforms, and some of the studies that you've got there are with dealing with anterior tooth wear. Equally, this can be applied to the posterior dentition. And certainly we've done some work where we've looked at single teeth, applying restorations, funnily enough, to treat cracked tooth syndrome on a back tooth. And again, this technique can be used for the management of other conditions in a minimally invasive way that are not just in the anterior dentition. And again, we've seen a very high success rate. I think our study with 140 restorations had a success rate somewhere in the region of 97%, with occlusal contacts reestablishing in 3 months. So it can be applied equally in the posterior dentition as well.
Absolutely, and I think we will look into that with some clinical examples. But essentially, as you rightly say, this is kind of a lot of researchers have shown that it's quite a high degree of success with using this technique. And of course, being additive, the other thing I like from it from a practice point of view is that, of course, using a material which is perhaps adjustable and you can add or subtract to allows for a area of safety margin with these cases as well. But the success rate, a lot of researchers, and as well as you mentioned, our work on cracked teeth syndrome, the success is quite high using this technique. So primarily, if I use this very historical case, and I know, Shamir, you're quite familiar with this case, it's done a number of years back in the 80s, where essentially we had this sort of platal wear of 3 to 3 upper. And this is kind of looking at it from Dahl's concept, where you actually have a Dahl appliance, which is a localized splint. We'll talk a little bit about splints later on, but there's a localized splint where you actually have a bite platform which is on the anterior teeth, so the posterior teeth are separated. And what we see in roughly approximately 3 months or so of wear of the splint, that the posterior teeth have regained contact, which is a kind of a combination of condyle repositioning, intrusion of usually the lower anterior teeth, and extrusion of the posterior teeth. So it's a combination of those effects that give this a space palatally on these teeth that we are concerned about. And in this particular case, this was done a number of years back, is that I'd used a precious metal gold alloy, which was heat treated in order to bond this with Panavia. And reviewing this case after 21 years, what we see is that these metal veneers are still intact and in place, which to me kind of said that Panavia is a damn good cement, and so is enamel bonding. But the other thing was that these restorations must have been in a harmonious position, because of course there is a lot of use of these restorations of the opposing teeth actually biting and moving against it. So this was the concept originally, how we did this. And I think you've done a few cases with this, and you used a slightly different metal, I think, on this.
Yes, I've used nickel chromium based, similar to what we might use or materials that we might use with traditional resin bonded bridges, and they can be used in very thin sections. And again, as you said, gold needs to be treated with its low surface energy for it to predictably bond. With those metals, they bond very well, and you can use them in ultra thin sections. And the advantage with using this as opposed to the removable appliance is that patient compliance is taken out of the equation. The big issue, however, as we can see with the gold case, and certainly with nickel chromium, is you get that dulling on that incisal edge as you do with a resin bonded bridge. And I think, as materials have evolved, as we'll show, there's ways of bypassing that. But certainly, I would still offer this as an option for some patients where they kind of think, well, I want something really durable there, where there isn't much incisal edge loss. My experience, I've had very good success rates using metallic alloys for the treatment of these sort of cases.
Absolutely. I think this is a historical case, and I think this is how I did it in the 80s and so. But nowadays, of course, when we're looking at these cases, we eliminate the appliance stage completely, and we're going for applying direct composite restoration here to recover the lost enamel that's been there. And then when we initially place it, the posterior teeth are of course separated, and then they come together over a period of time. And then of course we've sort of addressed this aesthetic issue with the patient as well. And then the longevity of these restorations, of course, are very good. This is an 8-year recall of this case where the restorations are still there, and the guidance that I prescribed on them is still being maintained. But of course, this is now going into a longer period of time. One of the things that we're finding out is that these restorations, particularly anteriorly, last very well long term.
Yeah, and this is one of the research studies that we're doing at the moment. We're looking at the largest number of restorations monitored sort of past the 5-year mark, and our sort of initial, and it hasn't been published yet, but the sort of initial analysis has shown that these restorations can work very, very well. It's important that enough material is added. If you add very small amounts, the material will break. And also patients do need to be aware that maintenance will be required, but it can offer a very good treatment protocol and an outcome.
Indeed, and I think with you raised an important point there. That if you are using a direct composite material, then maintenance is important. They do need maintenance and polishings and monitoring, of course, long term. And so with these applying this principle, of course, we can also do this for lower teeth. I know the cases we've shown is upper teeth, where this is essentially an older patient. She's about 75, 76 years old, where we've I've built up the teeth on the lower with a direct composite, and there are lots of techniques for doing this. And around about 3 months' time, we actually have the re-establishments of the contacts. What's quite interesting, I thought, in here is that a 1-year post-op, what I wanted to show is that if you have a look at the immediate post-op view on the top right, and I built up the canine in a particular contour, but in about a year's time, this canine actually wore down. So it was this kind of the composite sort of wore down to a prescription, which was more harmonious for the patient's functional aspects. So on both the threes, we saw that the composite actually sort of wore down. And what I'm finding clinically is that with these restorations, if a chip occurs, it usually occurs very early in placement, and usually signifies that it's probably beyond the tolerance level, or perhaps it's the material. But the other thing that happens is that there is a wear pattern that actually happens. And what's interesting in this case is that this happened in 1 year fairly quickly. But then if we see the same case in about 5 years' time, what we'll notice as I'm checking through this patient on the occlusion, that the canines have kind of then reached a stable position for a period of time. So in other words, the first bit of wear happened very quickly within the year, but now that 3 that you see has kind of stabilized at that. It's almost this sort of functionally guided occlusal prescription that's been formed. So this is where the direct composite actually does lend very well, because sometimes we build it up aesthetically to a contour, but of course the functionality then dictates, brings it to a particular shape, which is more conformative from the functional aspect of the patient. That's what my findings, and I think you've found similar sort of response from that as well.
Yeah, absolutely. What I found with these sort of cases is that the failures kind of happen in the beginning, and then once the occlusion establishes, it tends to sort of settle down. And part of it is that distribution of the occlusal loading. Part of it is that's we've discovered what scheme works. And that's the beauty with this material, in that you can do adjustments, do repairs, take away, add, which you can't do with indirect materials. And obviously, it's an inexpensive material compared to using ceramic. And this is, certainly the approach that we take when we teach, is to use this technique of sort of establishing the patient's acceptance and tolerance in a minimally invasive way. But yes, we do find, and even the research does show that, the 2 biggest studies, both which have been done by London groups, in that when you're looking at this sort of dial approach, you can expect to see a lot of need for repairs and refurbishment. Whereas when you're looking at cases where there's generalized wear, where the whole occlusion is being managed, I think you see the research seems to almost show that you see less failures, certainly in the short term. But my experience is very similar to what you've had.
Yes, indeed. And I think the other thought that always I have when I look at these cases and I see this adaptation of the shape that I have kind of the material, is that what the consequences would be if a particular material was too hard and it didn't lend to kind of this functional adaptation that happens on the material, and it's kind of food for thought, of course, the way that would respond, and of course, looking at these, we're looking at anterior cases, and as you rightly point out, this is something that we can also apply this principle to localized posterior wear as well, albeit this dial phenomena particularly relates to the anterior teeth. But here we have the scenario, which you've mentioned this research that we did, where we had cracked teeth, and I know this lecture is not about management of cracked teeth, but where we kind of had an isolated tooth that was high, and then how the occlusion reestablished around it. And this, of course, lends quite well to the treatment of localized posterior wear. And here's a case where essentially there's just 2 lower molar teeth that have worn down, causing sensitivity and food impaction for this patient, where we've kind of actually added on to these teeth. And you can see this again, it's a very historical slide. It's a case that I did several years back. And I've just added composite in a sort of a flat architecture, but immediately it obviously opens the patient up, particularly if it's done in the back teeth. But it's quite interesting how the reestablishment takes place of the occlusion. And what's surprising here, this is a long-term sort of view of it, is how the composites have lasted in the back. I always thought when I did these restorations posteriorly, is that the material would not be strong enough, and the intention is to sort of flip it to something that is a little bit hard wearing. But I have been surprised how these composites last. There is showing some wear after 11 years, but there is the same phenomenon being applied to posterior wear, localized. Yeah.
Logic would kind of dictate, with molars being close to the jaw joint, with the sort of nutcracker design, with the leverage principles, that you would expect to see more wear and tear, more failures with these restorations the further back you go, especially with the sort of type of material that we're using. And again, I think, when you're doing it, it's important to ensure that you get the right thickness, you've got the right compressive strength with composite. But again, as part of the informed consent, you and I both know as practitioners, that, patients are made of the risks, aware of the risks of, extra risks of failing, the further back you go, and to not expect too much. And it's important to manage the expectations, because these are very complex cases to deal with. And things can sort of go wrong, and they can be fixed, if you like. But patients just need to be aware of, what they're kind of in for.
Absolutely, and certainly in these sort of scenarios where we do have isolated posterior teeth, it is possible now just to deal with those particular teeth. And here I built up with a direct composite. I've given it a little bit more occlusal form because it was easier to do, and of course this can be sort of then the occlusion reestablishes as a result over a period of time. So we're just basically dealing with the tooth that is worn and leaving the ones that are not worn alone in these sort of localized cases. And similarly here, where you can actually see an isolated tooth, here I've kind of done the same sort of scenario where I've built it up, but given it a very flat occlusal platform, so that there's not much lateral loading on these teeth, and allowed the occlusion to reestablish. So it allows you to sort of cherry pick almost the worn teeth and sort of build them up on there. So this phenomenon is quite useful in the treatment of these. The list here really is just a sort of a summary of the things to perhaps look out for when you're dealing with these, and I've just made a list here, and essentially a lot of it kind of makes sort of logical sense about not being involved in that. I'm not going to read through this list, it's sort of everybody able to see this. I've put a question mark on not after orthodontic treatment, particularly because I'm assuming that the tooth has been moved, and therefore any other further changes, you may have to be a little bit more careful. But I think I don't know if there was anything else you wanted to add to this list, Shamir, at all?
Yeah, I think looking at the eruptive potential is very important, and also careful patient selection. Where you've got these things with TMD, etc., etc. I think my sort of feeling in general practice is that dentists applying this approach, and that's fine. But if you're looking at getting appropriate success rates, patient selection is very, very important. That you're looking at that eruptive potential. So if you've got someone with open bites, for instance, where you may look at that, or there's ankylosis or implants, for instance, you've just got to be careful. I'm not saying no, you've just got to be very careful with case selection. And certainly when we looked at our cracked tooth syndrome study, where we had 97% teeth re-establishing contact within 3 months, which is a lot quicker than what we usually see in the anterior sections, sort of 7-8 months, etc. But patient selection is very important to getting good success with this treatment approach.
Yes, indeed, and I think it's important. The selection is very important. The other thing I was going to add is a lot of the times when you have these patients with very, very prominent mandibular and maxillary protuberances, bony protuberances, they don't respond very well. And as you rightly say, the eruptive potential has to be carefully evaluated in order for this to work. Ideally, on the cases, the success rate is, as we've shown earlier on the literature and the research, the success rate is reasonably quite high with this approach. And when we're looking at generalized tooth wear, of course, as you rightly point out, we're actually looking at all the teeth. And again, it can be done in a sort of using composite material, where this is a sort of a generalized approach where we're not allowing certain teeth to come together. And sometimes on the posteriorly, I use it as a sort of a flat occlusal plane, so almost mimicking a occlusal splint prescription, but it's affixed in the mouth, or indeed you can actually use certain other materials posteriorly if you wanted to have a scenario where you wanted better, wear resistance posteriorly. And of course, here I've used gold at the back. I guess there is some scope for ceramics nowadays as well. but I have been surprised at how well composites last, particularly as you mentioned in sort of generalized wear cases where all the teeth are being built up and how they last. But there is this sort of option of doing it. The main thing to point out here, of course, is that we're allowing an additive approach, minimally invasive, and increasing the vertical dimension here. And I think posterior, you mentioned in your studies that when you're doing generalized wear, composites tend to last, but I've sometimes had to sort of replace it with a better hard-wearing material at the back.
Yeah, I mean that's sort of my clinical experience, and sometimes it's horses for courses. You see different things behaving slightly differently in different patients' mouths depending on the etiology, how well you've managed to control the habits, etc. So yeah, certainly the research work that we're doing, what we found is that molar restorations in composite are almost twice as more likely at risk of failure, and by that I mean non-catastrophic failure, chips and little fractures. Although we've got a very high survival rate, but molar restoration they do present an extra bit of challenge, because of the loading, etc. And they're technically more difficult to do as well, the further back you go. But there's a variety of materials that are available to us to use, and you bring these up in the discussions that you have with your patients.
That's absolutely. And this is the same patient after about a 5-year recall, and now this has been going for about 10 years now, and of course, coming back to the consensus when we're looking at severe tooth management here, and as you rightly say, you have to establish the diagnosis, the prevention, and the restorative treatment should be as conservative as possible. The treatment options should be carefully outlined for the patient so that they're able to basically participate in the decision-making process and they become part of this, and get informed consent, which is very important. And there was an area here where we've actually left in the consensus about that sometimes invasive restorations may have an option. And this was in the consensus paper where sometimes you may have to resort to invasive procedures, but I have to say in my clinical practice, predominantly it's been an additive process rather than a subtractive process in my practice. With this sort of scenario of this is you remember Shamir, this is Dr. Fuito, a wonderful surgeon, clinical surgeon, who's one of our MCLIN students a few years back from Spain, and who's written with us on our papers. And he did this particular case with the crown technique, where essentially the implants are replacing where the teeth are missing. But then he's actually used crown lengthening as well as full coverage crowns in these cases. On this, and this is one of his cases. But I have to say, and I don't know how you feel, Shamir, is that my practice has been primarily additive rather than a subtractive approach. This approach I find very much in a minority.
Yeah, agreed. Again, the sort of additive approach gives you that scope to verify the patient's acceptance of the occlusion, the aesthetics, etc. I think it's just that much more risky when you're almost going from this stage to the indirect restorations without anything in the interim. Yes, you could have provisionals, but by the time you've applied those provisionals, you've taken away a lot of tooth tissue. And I'm always mindful of that prospect of risk. But one of the reasons why we end up going down the route that we take is you have those discussions with your patients, and that yes, the composites will need maintenance. Crowns may not do, certainly in a shorter period of time, but you've got to present all of the options to your patients, and obviously then it boils down to what you would recommend as well. But certainly I feel a lot more comfortable having this sort of the minimally invasive approach, which allows us to sort of almost test drive things, and it just makes things that much more predictable. Yes, obviously going for these in the longer term may be an option. And certainly when I give my treatment plans, I would bring into that, the costs involved, etc., with these sort of things, and what, the longer term requirements might be.
And this, I mean, I like Trevor's work, all the research he does is wonderful research he does, and this is what this one kind of highlights here for me, that the failure or the risk of losing the tooth following full coverage crown work is a lot higher than from larger restorations with composites. So it's a wonderful work that Trevor did, with lots of looking at these sort of how a particular treatment item spanned out over several years. And this also rings out to me always that the crown tooth, full coverage tooth, although the intervention time might be longer where you don't have to intervene it, but the loss of tooth is much more a feature with i.e. a catastrophic failure rather than a larger composite restoration.
Yeah, I mean, this is another example of Trevor's contribution, if you like. That there's been a lot of this kind of very helpful data. When we're looking at tooth wear, there's very limited data on how indirect restorations perform. Certainly, there's one study with approximately 160 anterior zirconia crowns, which were reviewed up to a mean observation time of about 85 odd months. And what that study showed is that there was a 15% failure rate, which is possibly less than what you might get from an annual failure rate with composites. But those 15% of failures were catastrophic. That was the tooth that reached the end of the line. Now, if you're looking at somebody who might be in their 30s and you go down that approach, I guess the question to ask is, well, where will we be when you're 60 with that level of failure? And I think that all is built into the process. And as you said, yes, with crowns, you may see fewer, the lower needs for intervention, but where you're going to be 10 years down the line, and we do have to think like that. But as a consensus statement says, and as I'd agree, that doesn't mean that you say you rule the crown discussion out of the equation at the beginning. That has to be put forward to patients, in a clear, logical way, so that they can make that informed decision.
Of course, and it'd be kind of an age-dependent thing as well. If you've got a sort of a advanced patient age where you're looking at, so there's all that factors that come in on that. It's just sometimes if you are looking at ceramic as an option, there's doing something in sort of two parts can help if you do have to sort of so that you don't have to cut a lot of tooth out to actually get the path of retention right. And this is just a technique whereby you kind of make a sort of a ceramic coverage in two parts, and you enclose a sort of a worn tooth completely in ceramic if you wanted to. So this actually kind of prevents any major tooth cutting, and one of these techniques that can be used for scenarios like this, minimizing the tooth, minimizing tooth cutting. And of course, we're going into the monitoring and maintenance phase now, and finally looking at study class, clinical photographs, silicone indices, and software imaging. I think they all have a role to play. Clinical photographs being standardized and then being able to sort of replicate them with time to actually observe the changes, and of course we also have software imaging. And I think that Shamir, you have looked at this in sort of from a research perspective, the role of software imaging and how to monitor this tooth wear long term.
Yeah, it's part of my research. I spend a lot of time scoring grayscale models like what we see on the screen here, and the sort of research that we've found is that clinical observations are excellent. When you're using study models to monitor wear, the difficulty is you can't see color changes, and with early wear, having a look at those subtle color changes, and you see slightly more yellow, especially in the sort of non-occlusal, non-incisal, and those cervical areas, is really critical to getting the diagnosis right. With the grayscale models, again, although you can sort of zoom in, you can't have those color changes. With study models, you can sort of visualize and maybe run your finger across where you get that tactile perception, which grayscale digital models don't offer. And the research that we found is that certainly for looking at monitoring occlusal wear with study casts, with gypsum casts, you get a lot more sort of consistency with the sort of assessments, which is not as good with these, with the digital scans. But I think the future really is with the digital scans where you can use sort of subtraction techniques which can allow you to sort of monitor progression, or will give that scope to monitor progression to quite a high level of accuracy, and there's evidence to support that. And I think as the use of digital technology sort of advances, I think we'll see a lot more of that, and the use of sort of I can see the future being algorithms based on progression to help treatment planning as well. But I think that's quite a long way down the line.
Yes, I think so. And I think it'd be good, actually, one of the things I'm looking at in my practice with looking at software imaging and digital imaging is, of course, it allows the patient to also visualize a change, which is quite important because these changes happen slowly over time, and sometimes the patient doesn't quite appreciate what's going on. So it's sometimes good to have some sort of way to actually involve the patient in the discussion process of the problem that there is. And of course, particularly if it is symptomless, to be able to show them sort of categorically whether with an image, a photographic image, a digital image, and or a model of the rate at which the tooth wear is progressing. So I do feel it's important, the monitoring process and engaging the patient. And as you say, I think digital in the future is something that we're looking towards, and it may well have a role to play in this. I think we decided to actually take the questions through after the end of the second session, but just to summarize, really, this was a kind of a sort of a quick run through of the sort of the tooth wear and sort of sharing with you our work, the research that we've done, and particularly the clinical observations that we've had with our patients in practice, as we both treat patients like this in our practice, and the way things, the understanding has developed. And this kind of gives us sort of an overall view. I know there's a few areas that we didn't touch upon, given the constraints of time, but there's lots of other things, like, for example, managing things, catching things early, maybe introducing very simple procedures like canine rises in order to sort of protect posterior occlusions from wear and catching them early. These things also have a role to play, but we try to give a sort of an overall view of management of tooth wear. And thank you very much for your attention. I'll pass on to Shamir now, so to actually say a few words from there. Yeah,
I mean, again, thank you for your attention as well. And not really much more to add to what Subir has said. It's just that this is a very sort of exciting area of dentistry, restorative dentistry, where there's a lot of developments and a lot of things happening. So watch this space, kind of thing.
Thanks so much, chaps. That was absolutely fabulous. That was really, really good. Thanks for the plug as well, Subir. I'll keep paying you. And I love your classification of the etiological factors. I read that first in your book, but I think that's really I think that's a great classification. So I think we're having a short break now for about 5 minutes, and then the gentleman here will be back with more interesting stuff. I think it's a fabulous way of presenting it. This conversation is so relaxed and so nice. Thank you so much.
Thank you.